I'm Mara Antonoff, a thoracic surgeon at MD Anderson Cancer Center, and I'm here with Anna Olds, who has a couple of great abstracts that she's presenting here at STS. Dr. Olds is an I6 resident at USC, and she's done a couple of investigations looking at fertility and childbirth and pregnancy complications in cardiothoracic surgical trainees. Can you tell us a little bit about how you undertook these studies? What was the methodology?
Thank you, Dr. Antonoff. Nice to be here. Thank you. So we really started these studies because a lot of work has been done in general surgery and a lot of policy changes have happened recently to protect female trainees who are pregnant and having children, as well as trying to educate young women in surgery about the risks of delaying pregnancy. Female physicians in general, but especially surgeons, do tend to delay pregnancy and starting their families due to career prioritization or fear of judgment and stigma while they're in training or in their early career. So we really wanted to kind of survey the landscape in cardiothoracic surgery and see, well, what is happening? What is the contemporary landscape of family planning? What are the risks? What are the complications happening so that we can kind of do something about it?
Yeah, and so the first question you asked was the differences between men and women cardiothoracic surgery trainees and how they were planning their families and experiencing those life events.
So we did a national survey that the STS sponsored. We surveyed all male and female cardiothoracic surgeons and trainees across the country, and we asked a series of questions. It was a fairly intensive survey, so we thank everyone who participated. We asked general questions about relationship status, practice setting. We asked about children. How many children do you have? Have you had children? Do you have the number of children you want? And we interestingly found that female cardiothoracic surgeons have significantly fewer children. Less have children, but they also have significantly fewer children. And fewer female surgeons have the number of children that they want for their family naturally without the use of assisted reproductive technologies, surrogacy, or adoption. We found that male cardiothoracic surgeons are more likely to have a spouse that works from home. So, I think those are important things to keep in mind as we think about the landscape.
Sure. And then obviously with those results, we want to think about how we can help support cardiothoracic surgeons in the future. I think probably some of those results need to be taken in hand with the results of your other abstract that you're presenting as well. And maybe we need to come up with an approach to solve all of these issues. Can you tell us a little bit about the other study that you're presenting?
Yes, so out of the same survey, we included male surgeons and female cardiothoracic surgeons with at least one live birth. And we asked a series of questions about their pregnancy experience, complications. We asked about their work schedule during pregnancy, and we did a multivariable analysis for major antenatal pregnancy complications, including preterm labor, placental dysfunction, et cetera. And we actually found that female surgeons are at a significantly greater risk of having a major antenatal pregnancy complication. In our survey, 45% of the women surgeons had a major complication versus 27% of the partners of the male surgeons, the non-surgeon female partners, which was our sociodemographically similar control group. When we did a sub-analysis of female cardiothoracic surgeons only, and we found that age 35 or older or working greater than 12 hours a week in the operating room were significant risk factors for major antenatal pregnancy complications.
And the individuals who completed this survey, what stage of career were they at?
All stages. So the median age was about 47 for the male surgeons, and the median age for the female surgeons was about 41. We included trainees. There were no significant differences between groups in terms of practice setting, but the majority, like 75%, were in academic or academic affiliated practices.
Sure. Do you think that some of these findings that are being reported reflect risks that may no longer be the same? So, I have 4 children. My oldest is 16 years old. My youngest is 6. Certainly, I think that culture has changed somewhat since I became pregnant with my oldest daughter 17 years ago. I don't know how much it has changed. Do you think that among your data set, or if you were to look at those who are associate professor level, mid-career level compared to individuals who are maybe trainees, that the experiences might be different? Or if you're finding a risk factor of 12 hours in the operating room, I think that probably it isn't relevant which era we're using, but perhaps even just the culture of being able to sit down when one has contractions, or to be able to go to a doctor's visit when something doesn't feel right. Some of those things, maybe that might have changed in the culture. What do you think about all that?
I think it's possible, but I think the advantage of our survey is that it really is contemporary because the age of the surgeons is relatively young still.
Okay.
So I think it has gotten better, and I would assume that most people would agree. But I think there are still things that need to be discussed. We asked a series of questions. 80% of the women surgeons did not reduce their work hours or make schedule accommodations during pregnancy. And when we asked them why, we found that 50% actually felt fear of stigma and fear of judgment of being weak. And then the next most likely answer was that they felt guilty about burdening colleagues with extra work. So the University of Michigan, actually, Dr. Jenna Romano has done probably the most amount of work in advocating for things like this. She was instrumental in the ABTS leave policies that were instituted in 2020. And then she has also, she just published a paper with one of her residents at the University of Michigan on their pregnant resident leave policy.
Yeah.
So that's amazing. And I think the way that we kind of take this data and move forward is in a few different ways. I think firstly, education for young women surgeons and early career women surgeons, I think is important because a lot of people in this data has actually been shown in other specialties, but a lot of female physicians don't actually know what the risks are until it's too late. And a lot of them would have tried earlier had they known. So I think early education is really important, providing resources, an inclusive community for surgeons of both genders to have families, I think is very important.
Yeah.
Also policies that protect pregnant surgeons, that allow schedule accommodations, fairly compensate covering colleagues. I think all of those things are important considerations that maybe we think about and take from this.
And I think even just disseminating the information is important, not just for the women who may be childbearing to know what their risk factors are, but for their colleagues to understand as well. Unfortunately, there is that stigma of being weak, and hopefully through the several years of the pandemic, we've maybe changed culture a little bit to enable people to take time for wellness and health, but these are still issues that women face, and I think it's valuable to disseminate the information so that we can all support the workforce appropriately, including the male allies as well as the women who may not have children or may not be experiencing pregnancy, or are the colleagues of these individuals. So beyond presenting here at STS and publishing the work, what else do you think we can do to help educate people?
So I think there's a couple of things. I think providing resources and information for early career physicians about, egg harvesting, about freezing embryos, just education about what actually are the risks of delaying pregnancy.
Mm-hmm.
We know in OBGYN data that advanced maternal age is a risk factor for plenty of complications. So, but that's not the only thing. And I think in training programs, for example, having policies like the University of Michigan's policies where it is okay to adjust your schedule and accommodate, and you have mentors and allies within your program or within your department, or if you're in practice, you have allies and your colleagues who are, being fairly compensated, but also a culture of inclusivity, I think is important.
Terrific. Well, I really look forward to seeing the eventual publication and, of course, the presentations here at the STS. So thank you so much for your time.
Thank you.